Hello, everyone. Welcome to the webinar, Confronting the Affordability Crisis, Strategic Solutions for Health Systems. I'm Maria Castellucci with Modern Healthcare, and it's my pleasure to be introducing this webinar today. During this event, we'll be sharing for healthcare providers strategies to address affordability upstream to improve both patient experience and financial performance. We'd like to go over some technical details before we begin. Those of you in our audience are in listen and view only mode, but we encourage you to participate. Here's how. Throughout the presentation, please enter your questions in the chat and click send. We have saved some time near the end of the webinar to answer your questions. You could also use the chat should you need any technical assistance during the webinar. We'll also be doing a live poll, so please participate. We'd love to hear from you. Finally, we'd like to thank the sponsor of the webinar today, Cedar. Thank you so much for your support and for making this event possible. I'll now hand it off to our moderator today, Laura Herman, Vice President of Cedar. Laura, the floor is yours.
Thank you so much, Maria. Really appreciate that. Thrilled to be here with everyone today. By way of quick introduction, my name is Laura Herman. I lead our partnerships team here at Cedar. Really excited to speak with you today. And I have the pleasure of being joined by Dr. Sunny Eappen. And Sunny, I'll hand it over to you to introduce yourself.
Thank you. Thanks, Laura. Thanks for inviting me to join you. Sunny Eappen, I'm the president and CEO of the University of Vermont Health System. Been here for about 2.5 years. I'm an anesthesiologist by training and ready to get started.
Wonderful. So as I page forward, I will confirm that everyone can see my slide. And what we're really excited to talk to you about today is the challenge, the very sobering challenge that our industry is facing. The affordability crisis is deepening. Patients are continuing to take on a rising share of healthcare costs. And providers, as you know, are struggling with low and decreasing collection rates and increasing financial pressures. At Cedar, this is what we spend all of our time thinking about and watching where the ball is going. Our vision and our ethos is to enable providers to connect the health system around patients. So paying for care never actually compromises health. Maybe put another way, that healthcare affordability challenges aren't just about building efficiencies or optimization. There is no amount of billing efficiency that will help a patient who's faced with a life-altering $10,000, $20,000 bill that they ultimately can't afford. So what we do at Cedar, very specifically, is provide an end-to-end solution for the entire patient financial experience, all the way from pre-visit estimates through post-visit billing and payment. And we match-make patients with integrated and personalized financial navigation resources and tools like custom payment plans, payer benefits, HSA, FSA balances, and Medicaid enrollment to ensure that their financial experience is just as strong as their clinical experience, and that we are ultimately helping patients understand, afford, and resolve their bills. So what we'll delve into together today and what we'll explore is connecting the dots to affordability solutions, how different AI-driven strategies can really transform healthcare finance and also address complex patient needs. And very excited to hear perspectives today from Dr. Eappen and everything that he's led with his transformation at UVM Health. So as I page us forward, I think it's important that we talk for a moment about how we got here. So before we talk solutions, we need to understand the problem. This is staggering, and I suspect that everyone on the line has some familiarity with this. Healthcare spending has increased almost 18% over the last 50 years. That is a whopping 700% increase. And I know I'm not telling you anything that you don't know, but we're going to get there. So patients are increasingly your fastest growing payer. Patient out-of-pocket responsibility has grown explosively in the last decade. You can see the graph rising from 2016 through 2024. And just over these last 15 years, patients have been absorbing or really shouldering increased financial burden of care at an accelerating rate. So what this means is that just 5% of patients who were enrolled in a high deductible health plan in 2007 we now see close to 51% of patients enrolled in a high deductible health plan today. And as many of you know, this is actually the hardest bucket of accounts receivable to collect on. And it just became your fastest growing payer category. And we posit, and a point of view that I'm excited to share with you all today, is that treating this bucket of AR like your other payers is not the winning strategy. Maybe to think of it another way, rate renegotiation is not the way we're going to dig ourselves out of this mess. And it's not just that patients owe you money. The way that they owe and the funds that they owe is fundamentally different. So while we know that deductible spending is on the rise, and everyone is aware, these are large, unpredictable balances for patients that are collected after the visit. This comes at the same time where copay spend has been decreasing. And this is a fundamentally different motion for revenue cycle and healthcare leadership teams to collect on. A copay can be collected at the point of service by the front desk staff, whereas the deductible needs to be chased down or followed up on with the patient after the visit. And that is fundamentally much harder to accomplish and a greater burden for patients to shoulder. So we see enormous increase in deductibles rising while copays decrease. So we've entered what we at Cedar recognize and call the self-pay era. And while we've seen true self-pay patients climbing, we recognize that across our partners, patient responsibility owed by uninsured patients has risen, with about 35% of all outstanding AR billed to self-pay. We observed that was an 8% increase among our clients alone in just a little bit over a year. So as uninsured patients now approach almost 40% of total patient responsibility, we believe that this marks a pretty critical paradigm shift and a new era of healthcare with a very different set of strategic imperatives. And yet, legacy technology and strategy have not generally adjusted to meet this new reality. So we observe that EHRs, traditional billing practices, and platforms continue to offer a one-size-fits-all approach to patient collections, when in reality, the nature of the patients from whom you are collecting and the amounts that you are collecting from them has fundamentally changed. So I'm going to move us into a poll and hand it over to our modern healthcare colleagues. We would love for you to engage with us. What percentage of patients do you think are either underinsured or uninsured entirely? We're going to give folks maybe another 30 seconds to enter your guesses, answer the question. If you've been following, I've given you a lot of different data points that can inform your guess. Okay, I'm seeing 40% of respondents choosing option B, 44%. Others think 33%. Let's give it just another moment. It's fun to see the spread here. Okay, I'm going to give us about a 10-second countdown. So if you haven't voted, please enter your guess now. And our winner, folks chose option B, 44%. Interesting that we have a tie for 33 and 40%. 44% is correct, according to a recent study by the Commonwealth Fund. And this is staggering that nearly half of all patients categorize as either uninsured or underinsured. And the implication on the relationship with your patients is absolutely critical. that understanding how you can help patients who are experiencing this financial burden navigate the patient financial journey is absolutely critical. And I'd like to spend a moment, making sure that we can talk as well about the underinsured patient population, because this is an emerging group that stems out of recent policy and legislative shifts across the country. So I will move us forward and continue to drive home that patient out of pocket is and the composition of those out of pocket costs and the patients who are shouldering them is changing rapidly. So we've already established that nearly 40% of patient out of pocket dollars come from those without coverage, and that nearly half of all patients are either un or underinsured. And the reality is clear. We have to do something different about this to meet the moment where we live in a country and a world with best-in-class clinical care, but recognize that we are really failing our patients in terms of how to make healthcare costs understandable to them. So, Sunny, I'd love to ask you for your perspective. How are you seeing this affordability crisis play out in your work, either at UVM Health or across the country with your peers?
Sure. So where we're sitting in Northern New York and Vermont, our patients are split. About a third of them are Medicaid, a third of them have Medicare, and then we have that third that's in that commercial pool. For our Medicare and Medicaid patients, the affordability crisis really plays out largely in social determinants like food and housing insecurity. We have a very generous plan where we largely, the out-of-pocket expenses are largely pretty low for them for the direct care that we're providing. So our job there is really to work hard with, how do we break down or identify those barriers and then try to break them down, and how do we give them access to food or administer their medications or make sure that they're actually picking up their medications. That's one big piece. The other part of our patients, though, covered by the commercial insurances are the ones that we really do worry about. Either they're covered through their employer or through their own businesses. And I think that's the population, Laura, for us, that you're really hitting on, is that that's a group of patients that I think we'll talk about a little bit more coming up, but that their costs, their out-of-pocket costs, can be particularly challenging depending on the type of plan they have, how high their deductible is, et cetera. So I think we're definitely seeing it, and that's a challenge for us and our patients. And we've largely, resorted to using financial counselors, which we have at the ready at almost every site that they come into our hospital. But if that part of our population continues to grow, that will become challenging for both us and for our patients, and really unsustainable moving forward.
Yeah. Well, I appreciate you sharing, and you've obviously done so much work to provide many layers of support, and of course recognize that Vermont has probably higher levels of coverage, as you mentioned, than other states across the country, and that other folks who are on the line might be grappling with. So I'm curious if you have any advice for your peers for ways that they can be thinking about marrying up an evolving legislative environment with this changing demographic and population shift that we're seeing to see more underinsured patients that health systems need to interact with.
Yeah, I mean, I think the challenge that I see coming up and the things that I'm worried about certainly are with what we're sensing coming from the federal government around changes in Medicare. And in Medicaid in particular, that there's a fear that we are going to really get hit and the Medicaid contributions are going to drop. And so the consequences of that essentially are that anywhere where we've got a system where Medicaid really doesn't cover the cost, any change, any decrease in the way that Medicaid funds out is going to put a larger burden on our patients and a larger burden on us as providers. And so we're going to have to fill that gap we'll fill that gap somewhere. From a legislative point of view, our real emphasis has been trying to convince our legislators that it doesn't matter if it's a workforce or work requirement that you're putting in, or a decrement in how you're going to help support those patients in any way, whether that's enhanced tax credits. Any reduction there is going to impact our patients. So that's where we've been spending time in the legislative arena for that.
Yeah, I can imagine, and I appreciate all of your proactivity there. There are no shortage of policy and regulatory headwinds that we are monitoring very closely across the country, and I hear every day from provider executives that are concerned about possible changes in Medicaid funding. And I think exactly as you just said, Sunny, we will have to close the gap, is the critical reality. We just released a white paper at Cedar on the evolving affordability crisis and what it means for provider financial performance and operations. And we believe, and I'm going to speak to some of this, that there are specific actions that provider organizations can take to leverage technology, to leverage agentic AI, to meet patients where they are with the right information, the right options to engage with, understand, and ultimately afford their bills. That is a critical piece of how we will close that gap. And as we look across the country, not just in the great state of Vermont, there's possibility for enhanced subsidies from marketplace plans expiring at the end of 2025. That's something to watch very closely as we're thinking about potentially underinsured populations. Of course, the ambiguity and uncertainty over Medicaid funding and potential looming cuts, and also potential work requirements that we're tracking for Medicaid beneficiaries that may change enrollment. So, lots to keep a very, very close pulse on.
Yeah, and I think even if you look at the current commercial population and the complexity in the different plans, and how they change rapidly, even after you've agreed and you've gotten a contract in place, they can change during the year. I think there again is technology has a huge advantage in being able to move as fast as those changes and being able to update that. That's faster than people, right? It's hard to keep track of all of those changes, both for our patients and for our providers, quite frankly, right? Our financial counselors struggle with that same piece. So I think there's a huge opportunity there if we can leverage that for the benefit of our patients and providers.
Yeah, well, I appreciate that perspective, and we obviously couldn't agree more that there's a critical role for technology and increasingly artificial intelligence to play, to shorten the distance, to your point, of people simply can't keep up. I heard from a health system in New York that runs their entire financial assistance policy playbook out of a literal book. So when a patient comes in, someone has to go and get the binder and open it up and turn the pages. And we know that solutions like that, while they may have served us to date, they simply won't scale for what the industry and patient dynamic will require going forward.
Absolutely.
Just to hammer this home and speak to what we view as a pretty sobering reality. If the percentage of uninsured patients grow, health systems stand to collect less. And to put it into perspective, we modeled out the direct financial impact of a sustained shift toward more patient responsibility with less insurance coverage. And our analysis that you see on the screen in a sensitivity analysis looks at the expected cash collections for various different scenarios. And these figures are very conservative. So we assume that constant, of total patient responsibility, constant medical inflation, constant operational factors, without considering any increase in underinsured patients. And what we see is that, ultimately this will lead to dramatic shifts in terms of, expected cash collected, a decrease there, and also more bad debt write-offs, higher cost to collect, sending more patients to collections, and then seeing more patients who are coming to seek care through the emergency department. So, we see very clearly that the business case for promoting affordability is clear. If we help patients understand what they owe, why they owe it, and how they can pay for it, that is a winning strategy to do well and do good for our patients and communities. And we play what we believe is a very critical role in helping health systems meet those unique needs of an evolving patient population. I'm very curious, and I'd love to see in the chat if anyone is already familiar with the concept of ALICE patients. And Sunny, you already alluded to this. So everyone understands what an uninsured patient looks like. The evolving definition of an underinsured patient, I think, can be best explained by the concept of ALICE. So even in a world where if those policy headwinds don't come to fruition, we still know what is certain in our industry is that we're going to continue to see increased cost share, more responsibility shifting to patients who all have different circumstances. So that's why in our white paper that we'll be glad to share with everyone as a follow-up, we take a closer look at who these patients are, what their unique needs are, and specific tailored ways that health systems are going to need to adapt to meet their needs. So ALICE is an acronym that stands for Asset Limited, Income Constrained, and Employed Patients. ALICE as a population earns just above the federal poverty level, but actually less than what it costs to make ends meet. So an ALICE patient is struggling every day with impossible choices. Do I pay for gas? Do I pay my power bill? And their medical bills are likely falling to that bottom of the list. So these are struggling households where hardship is pervasive. And we also observe, and this is a concept that has been developed and documented by the United Way, households of color are also disproportionately ALICE patients. I also hear, and Sunny, you even made this remark to me, that ALICE because ALICE works at the health system. So I wonder if you might expand on that for a moment.
No, absolutely. I think this is the patient population that I think we're most concerned about because they don't have that coverage that our Medicare patients have or our Medicaid patients have. And so certainly almost every one of the health systems that I'm aware of across the country has a self-insured patient population. So they're taking care of, their own system is taking care of the patients and their dependents. And when you look at the lower economic end of that, that's the $20, $25, $30 an hour, depending on where we're going, where we're sitting. Those patients and those families really struggle in this space, right? They're making really difficult decisions about, do I buy shoes and clothes and food, or do I go and get the health care that I need or my kids need? And I think this is the patient population that you're totally touching on, and that we are very, very concerned with. And I would just say that, so right now in Vermont, we cover a good percentage of this. So within the health system, up to 600% of the federal poverty level, we have some level of coverage. If it's 250% or lower, they don't pay anything, but they do start paying at a level at 300, 350, 400, right? So they're responsible for some portion. And even that portion of it, as your graph is indicating here, they have to make difficult decisions about what they're going to pay for. So I think you hit the nail on the head. This is the population that we worry about.
Yeah. I appreciate that, you have your eye on where the ball is going and that you're already thinking about this. You made this comment to me, and another a CEO of a health system in the Mid-Atlantic had the exact same reaction of, we don't just know ALICE as a patient, but ALICE is potentially, the sanitation services, a cafeteria worker at my health system. These are our employees in addition to our patients, and there has to be a better way of meeting them where they are. And I'm showing you a breakdown of, what an ALICE patient's household budget might look like. And the reality is that a large bill, right, particularly an unexpected balance, when we know that ALICE patients, potentially in Vermont and well beyond, are largely enrolled in high deductible plans. So suddenly, meeting a bill that's $5,000, $7,000 or more becomes virtually impossible for an income constrained household. And that's when you start to hear the feedback in your call center and the patient dissatisfaction and reporting from your billing team that ALICE patients are really surprised. What do you mean I owe $6,000? I thought that I had insurance. Or what is my insurance for if not to cover this? So we recognize that, there's a huge barrier here, and also a huge need to meet these patients where they are with tools and solutions to help them engage with their bill. Maybe another way to think about this is that these uninsured ALICE patients, even if they are insured, this is effectively a self-pay in disguise population. And hopefully this shares a clearer definition and helpful example of what this underinsured population is that we're spending so much time speaking about. So why is ALICE important? Well, ALICE doesn't just work at your health system, but in many states, upwards of 33% of residents are considered ALICE patients. We observe this in California, New York, Florida, recognizing the federal poverty level is different. But the number of, ALICE households has increased twice as fast as the number of total U.S. households in the past decade. So we believe that ALICE is a very, very helpful and nuanced lens to understand patients' ability to afford their care. And the reality is that there are many different types of ALICE patients. So financial strain isn't an identity, it can be a turning point. Many ALICE patients, and we've done extensive market interviews, patient research, they can pinpoint the exact event that changed everything. That, got into a car accident, someone got a diagnosis, someone had an unexpected hospital stay, and that's when, the very delicate balance was upset. And when you look at enough of these stories, the patterns emerge. It's not just anecdotes, but it's real data, and that's data that is informing the work that we do and our technology-informed approach at Cedar. And so these patterns offer a new way to understand and support patients. When you know which life events can typically destabilize different ALICE segments, you can actually intervene earlier, addressing affordability further upstream, exactly at its root. And through our qualitative research methods, through our patient interviews, we've identified 5 distinct archetypes that show exactly the different ways that patients can either become ALICE or struggle to pay, defined by 2 different key dimensions: the nature of triggering events, so medical versus non-medical, and their specific financial impact, a change in income or a change in expenses. And those 5 archetypes are: 1, suddenly self-pay patients who unexpectedly experience a loss in coverage or income due to life changes. It could be 2, cost burden patients whose basic expenses increase without matching income growth. 3, it could be treatment drain, so patients with medical costs that gradually or quickly deplete their savings or income. 4, it can be caregivers, patients who are managing their own care or that of dependents with limited or dwindling resources. And then 5, it's Gen Z builders. So these are young adults who are newly navigating healthcare with limited income and limited experience. And what we'd like to share with you is a closer look at some of these archetypes, and also really eager to hear perspectives from you, Sunny, and from our audience on the line of how you're meeting their needs, both at the national level and then specifically in your patient population. So I'd like to introduce you to a suddenly self-pay patient who we interviewed, the archetype that we've identified. And this is a patient who experiences unanticipated income loss and is ultimately unable to fulfill healthcare payments. So, for example, a layoff or a family income loss, or inconsistent income maybe coming from being a seasonal employee. And I'm curious, maybe Sunny, just to kick it off with you, given Vermont's expansive Medicaid program, if patients were to suddenly see a change in coverage due to lack of funding, it stands to reason that you would see an increase of suddenly self-pay patients who need other coverage options. So building on what you shared before, the work that you're doing with financial counselors, are you implementing any strategies to think proactively about how you might support more patients who are facing more economic hardship?
Yes, so it's a great question and a great point. So again, remember, Vermont has a very, very generous, I would say, program right now with their ability to cover, with the requirement, quite frankly, that hospitals have to cover that with no self-pay up to 250% of the federal poverty level. So that's one component. But it really is that Alice patient who is sitting with, it could be a sudden change in their income. They still have coverage, but that high deductible piece now becomes unaffordable. That's, I think, the challenging patient population where they become responsible for a chunk of their payment that they can't now afford as a result of change, maybe in their employment status, but they still have that insurance. Right now, we use our electronic medical record and our financial counselors. And so people come in, when we see that there is this challenge or the patient brings up that challenge, then they're immediately sort of shuffled over and there's a financial counselor to help them. The challenge, of course, are the ones that we miss. If that population goes up, then we don't have the number of counselors potentially that are there and ready to help them. So there's an opportunity certainly here for, again, using technology to expedite that, to have people be able to sit on their own and enter that information and then have a plan that meets their needs, come back to them. That's what we're trying to do with people, but there's certainly opportunities to do that with technology and then guide them to, what financial assistance programs are there that exist, what is their healthcare insurance cover for them, and to be really clear about that. I think all those opportunities are there, and we need to really move forward and be ready for that. So I think you're hitting the nail on the head again with these patients and these challenges that we have.
Yeah, and we're really excited to do that with you. I'm curious if you have any other advice or calls to action for your peers who may be, sitting in states with a very different population mix, right? Who might be thinking about Medicaid disenrollment as an immediate reality or something that they're reacting to.
Sure. I think the real challenge there, again, of course, is that if you're in a system or a state that doesn't have the supports to be able to push you in or help you to get enrolled into an insurance program, whether that's Medicaid or something else, then I think it falls on to our system, our providers, our hospitals, to be really prepared for that and to help. It's both the right thing to do for our patients to let them know, number one, here's what you qualify for and help them to get into that space. And then number two, to set them up front so that they're not overwhelmed with what may follow from that. So I think that early preparation and it means either you're using technology or you're using people to help folks guide that very complex pathway that currently exists in our insurance programs.
That's very, very thoughtful. And I love the idea that, you're talking about, which is something that we think very passionately about at Cedar, which I sort of shorthand for matchmaking, right? So how do you connect the patient with the resource, the next step, the resolution path that's right for them? And for certain patients, that might be making them aware of a payment plan, that might be making them aware of Medicaid eligibility and connecting. There's a lot of different solutions out there. So I've spent a lot of time dwelling on the gloom and doom. I've already shared the bad news. The good news is that there are many, many resources available to help patients with their financial needs and financial navigation. Okay, a little bit more bad news. These resources are unfortunately often unused, they're out of sight, or they're out of reach. So too often, this type of resource that can dramatically help an ALIS patient is not known to them. So, for example, did you know that over $132 billion sitting in HSAs goes unused every year? Or that 97% of copay assistance goes staggering? And 64 million uninsured Americans are eligible for Medicaid but are not enrolled. So this really illustrates that, again, the affordability challenge isn't entirely the result of lack of resources. What we're seeing is the lack of connectivity and a failure to connect patients with those resources. And that is precisely what we do at Cedar and what we bring to the patient financial experience.
Laura, I think that yes, technology is one way that I think that's the way to target that and go after this population. Otherwise, you have to have an amazingly robust system in place that both tries to capture those patients as they come in, enrolls them, gets them connected to these resources, and then continues to follow up with them, right, on the telephone, on video calls, however you're going to do that, to be able to say, hey, we understand that you've got this challenge now that we didn't appreciate before. Can we set up a payment plan? Or is it a young person that you can just text and say, here's the link, you can go right there? Or is it a different patient population that you're going to have to take through, right? Side by side, almost elbow to elbow support to bring them through. So I think lots of opportunities. Again, I would say there's people power there, or there's technology that you can use to help facilitate that. I think there are many different paths, but I think we're going to have to really be smart as our population becomes more needy in this space, right? So I think it's wise for us to think ahead and for on the provider side, on the hospital side, really plan ahead on how we're going to deal with these patients now.
Folks, I will note, I'm aware that my audio is not coming through clearly. I'm working on some troubleshooting while we're talking.
You got it. Actually, it's back.
It sounds like it's back. Okay, I'm glad.
It was my stall technique. It was helping.
I'm grateful. That makes us a good team. And thank you all for bearing with me. The difference between a monitor and a computer might get shifted at some point. Thanks for letting me know. You know, I always joke with you, Sunny, about your nirvana concept, right? Of what would it look like if we had the magic wand and we could fix everything that's frustrating us, that's making payment experience hard and painful. And I'd love it if you could share with our group the way you're thinking about this.
Yeah. So my dream state for our healthcare in America would be that there is no exchange of money or need at the point of contact of care. All of that is taken care of well before. And so either the insurance is done and we know when they walk in the door that the care that they need will be delivered and it'll get paid for. And the patient and the provider don't have to interact in a way that becomes an obstacle to that delivery of care. Or a step before that is, before you walk in the door, you really have a really clear understanding of what things are going to cost you, what the expectations are, and that there's a path to be able to pay for that, or here are the programs that you need to step into or that you're eligible for. All of that happening well before you walk into that doctor's office, get admitted to the hospital, go to the emergency room, whatever it may be. Similarly for your prescription plans. Now I think the Netherlands have come as close to this as possible, where people are, they're charged up front based on your income level. They get a card. You walk in, you hand them your card. If there's no exchange of dollars at the point of contact, as much as possible. That'd be my dream state for us. I don't know if we'll get there in our lifetime, Laura, but that's hope. Oh, I think you're muted now.
Indeed. Thank you. I love it. And I'm sure that folks on the line are going to have a lot of comments there. And I want to make sure, as I'm keeping my eye on time, that, we can save some time for that dialogue as well. But I get really fired up about your vision, and it's very aligned to our vision and, very simply what we do at Cedar. So, we firmly believe that the industry has to move toward financial navigation and preventative financial care. And this isn't some touchy-feely do-gooder thing. There is a business case and a business mandate that if we do not connect patients with the tools to understand and navigate their bills, that's going to, hit every organization's bottom line. So being a resource to proactively guide patients toward better financial assistance and affordability solutions is something that, we're very proud of the work that we're doing there. So what does financial navigation actually look like? You could think of this as Cedar powering a GPS-like tool to help patients really understand and navigate their financial obligation. And that is financial preventative care. Just like the preventative care that, you see your GP for, it's the same concept. And with AI embedded and AI real-time data integration, it's possible to actually match and connect patients to resources in real time. So, these are real screenshots of, what a Cedar-powered financial navigation experience can look like, where we might connect a patient to an opportunity for copay savings on a pharmaceutical bill, having a patient surface to them that we have their HSA integrated directly into their bill pay experience. And did you know that you have dollars sitting in your HSA that you can use to pay this bill instead of rifling through the kitchen drawers for your HSA card? Maybe that's just me. And then finally, also being able to really tailor a billing experience to meet patients where they are. So helping patients who may be eligible for financial aid to understand, we can connect you to either the health system's financial aid practice and policy, or perhaps this is a patient who's Medicaid eligible, connect the patients directly to eligibility screening and application. The idea is to meet the patient exactly where they are with the tools that they need that will allow them to afford and resolve their bills. So this is what we're really excited about and what we're doing. And with that, I'm going to pause and open the floor for dialogue and questions and further conversation.
Yeah, great. Thank you so much, Laura, and thank you, Sunny, for that excellent presentation. Really great dialogue. We have lots of questions coming in. I thought a good place to start would be, can you talk about how do you measure the ROI of investing in financial preventative care compared to managing uncollectible debt or charity care write-offs?
That's a great question. I'm happy to start, and then Sunny, I'll pass it to you for your perspective. I think that's deeply related to how you calculate the cost of collections, right? So the cost of writing patients off to bad debt is very, very high because that hits you in multiple places. Whereas if you can leverage AI technology to deploy affordability tools and also just reach patients in the right moment. So I'm not suggesting that every patient requires a proactive discount or financial aid. Sometimes it's just about reaching the patient in the right channel with the right message and the clarity of, you owe X amount, this is why you owe it, and you have dollars sitting in your HSA, that is going to
convert a patient, who may not have known how to engage with their bill before. So something that we think about is propensity to engage as a more valuable indicator of payment, frankly, than propensity to pay. And what Cedar is best at is engagement and engagement strategies. So how you measure the ROI, maybe to go back to your question, is Cedar's got an entire team devoted to what we call value analytics. And we do very robust ROI reporting of performance pre-Cedar, post-Cedar, measure cost to collect, decreases associated. But I would go back to, really thinking through what is the business case and the business cost of doing nothing. And we know if we do nothing, that patient debt will just continue to explode. Sunny, welcome your thoughts as well.
Yeah, so I'll take a much simpler stab at the ROI. It's really imagine if you did nothing and you look at what you're collecting. That is, that you walk in and you look at what percentage of your total patient billing are you actually collecting, and then then you get the understanding of the dollars that you're leaving on the table and what you're getting, and then you start calculating the costs of the things that you've put into place. And lots of people are in the middle of that, and this is what makes it challenging. But you have to imagine having nothing, and then you start having the financial counselors, the folks that call and follow up. Then you do finally, at the end of the day, put it to a collection agency. How much does that cost, and how much do you collect? And you do the math of how much did all of that cost me? How much additional did I actually get from that? And we do that math, and you want to make sure that the dollars that you're putting in towards the collection is actually gaining you more than it costs you, right? And I can tell you that we do, but it's not trivial. And you do, and we know that there are still dollars on the table, but there's a feeling that if we put more dollars effort into that the gain isn't going to be as great. So everyone sort of draws a line somewhere where they think, okay, I know we've got these many dollars left, but it's not worth it for us to put it in. And so I think that's where the opportunity for innovation and creativity come in. If someone comes in with an innovative process of saying, no, look, if you did A, B, and C up front, it would only cost you this much, and you'd be able to bring more in. That's the opportunity, I think, that we're looking at right now. We do this all internally, other than at the very end going to the collections agency.
Okay. Sunny, I want to stick with you. Can you talk about how does UVM balance financial assistance incentives with the need to sustain revenue and operational efficiency?
So I think that it's not a very complex equation, right? I mean, we exist to serve our patients and our communities. And so everything we do is about that. At the same time, we understand that for us to be able to deliver on that mission of sustainability, we do need to collect what we are due, whether that's from our insurance companies, from Medicare, from Medicaid, and from the patient portion of that. And so we really do try to balance that, and we try to do that in a way that is really connecting with the patients. We're kind and compassionate, and trying to understand that situation where the patient is also living in. Part of that is mandated. Like I said, up to about 600% of the federal poverty level, there's some level of assistance that comes from either the state or from us directly. And so we want to make sure that we connect on that level to be able to do those things. We have a number of financial assistance programs that are within our system and also outside of our system that we want to connect our patients to. And so we work really hard to do that. Partly it's we want to make sure that we do collect, and partly it's that we realize that the affordability issue is real. And we know that patients are making really difficult decisions. And so we want to be kind and compassionate as part of our mission to serve our patients and our population. So I know it's a more nuanced, complex answer that's not clearly mathematical, but that is what we're forced to do in reality.
Yeah. We did get a question from a registrant about the underinsured changes that we're seeing across the country. So is the change in underinsured a result of a shift in population? We're seeing more poverty, more people out of work, or is it a shift in population access to coverage like Obamacare, Medicare funding, et cetera?
Maybe I'll start with what we're seeing, and Laura, you can see more maybe on a larger scale. I think the challenge that we're seeing today is that in that ALIS patient, the patients that actually have insurance, their insurance costs are continuing to rise. And so either the employer or the patient has to make a decision about what they're going to do. So the employers are often saying, gosh, we can't afford, the small businesses can't afford to continue to pay these high insurance costs. So they're shifting more of the burden towards their employees. And then the employees have to make a decision about how much am I going to be able to pay, and do I need to move towards a higher deductible plan in order to be able to afford my insurance. So I think what we're seeing is, and this comes from the national framework of the challenges today, right, is that we have a large inflationary issue where the costs of our workforce are going up dramatically. Pharmaceuticals are going up, devices are going up, and we have a shortage of providers. All of those are increasing our costs. On the other side of the reimbursements are not keeping up with that inflationary pressure. And so we're stuck right now. So it's just more expensive to be able to deliver the same level of care. And that's hitting all of our population, our self-insured, our employers, as well as the insurance companies as well. They're struggling in that same space.
Mm-hmm. That was really well said. Laura, do you have anything to add to that?
I will come off of mute effectively this time. Sunny, I think you hit the nail on the head. And, what we see is the shifting of the cost burden. At one time, employers bore the cost of insuring their employees, and that cost has shifted. Costs of living have increased. I mean, do we need to say the T word and talk about tariffs? But this is such an uncertain economic environment that it's certainly a confluence of factors. But the rise of high deductible plans with the rise of costs, inflationary pressures, I think creates this perfect storm. And something that's always struck me in the patient interviews, the population research, all of the qualitative research that we've done into the ALIS population is the gratitude that comes through for the care that they receive. This is true of every population. People fundamentally want to pay for their care. In the same way that, you wouldn't dream of just getting up from the restaurant table and leaving without paying your bill, people want to pay for care received. People want to thank their clinicians, right, who have done life-changing things, but patients are faced with these impossible choices.
Yeah. Building off of that, are there policy changes either at the local level, state level, or even the federal level that you believe would significantly improve healthcare access for these ALIS patients?
So I think the challenge there and the data piece of it is to actually identify and target those particular patient population. So if you look at the total pool of commercial patients, there are many people, I'll put myself in there. Yeah, healthcare is expensive, but we can afford it. So you have to find that patient population in particular that is in that niche where they're employed, they have insurance, and yet it's expensive. And then you have to go and target that patient population to say, what are the opportunities to be able to help for your care? And we do things like in certain populations that we'll target, right? Patients that come to the emergency room repeatedly. Our care managers will work with those patients, go to their homes if they need to, identify what the issues are. And what you learn from that is that each situation is one unique situation. And that's the challenge, is that you've got to identify that group, that patient, and then go and help them. It's possible, but it's a lot of effort and energy to do that. And we've got to change the model of how we employ, provide insurance, provide coverage, and allow for payment plans that fit that need. That's the challenge for us, and feels very one-on-one right now, very personal, and it's hard to do it in a large population base.
Yeah, that's really well said. Are there any partnerships or collaborations that you believe could help bridge gaps in patient affordability?
Well, I mean, I think there, again, it comes back to, is it going to be a state? Are there going to be financial assistance programs? Are we going to be able to work better with our employers, our insurers, so that we're really meeting the needs of our patients? I think that's where we're at right now. That's the inflection point where we really need to come together and work together with our legislators, our regulators, our insurers, and say, look, here's the need. How do we come together? We're all trying to solve the same problem, but we're doing it in our silos. I think there's an opportunity for us to come together to do that. I think, Laura, on the technology side of things, I think you're the expert there.
Yeah. And, I think technology, in my opinion, is the answer that's going to drive change. I think we have to build a new system where affordability isn't the obstacle, where everything comes to a grinding halt. And we have to find new ways to navigate to not just the front door of care, but following through the patient's entire financial journey. And by the way, delivering a patient financial experience that makes them want to come back to the health system. We hear all the time that patients share, I had an amazing clinical experience, and then they get the bill and their sentiment changes entirely. So there is a critical business imperative to deliver a financial experience for patients that's on par with the excellent clinical care that all of your institutions deliver. And that's why we feel so much conviction around building navigation tools that customize the experience, tailor the experience, depart from our historic one-size-fits-all approach as an industry to get patients the information that they need at the right time to understand and resolve their bills. I think, Sunny, to your point, there are patients for whom healthcare is expensive, sure, but you can afford it. And those patients need a different navigation and payment experience than a patient who can't afford the bill. For those patients, you want to optimize for totally different things and provide them with convenient ways to get their bills on their phone and pay with Apple Pay and have an easy integrated HSA or FSA. So you just click a button, it's done. You pay your bill and you don't have to think about it again. And we recognize that for some of the patient population, that's the right answer. And for others, they need an entirely bespoke process of, let's help you understand what your payment plan options are. Let's help you understand what Medicaid eligibility or copay pharma assistance benefit might look like. And we're using technology and we're using AI to help do that, bring down the cost to collect, increase collections, and improve the overall patient financial experience.
Very well said. As we're starting to wrap up, I know we're getting to the top of the hour. I wanted to ask you, Sunny, a forward-looking question. So how does UVM Health plan to innovate around patient financial care in the next 5 years? So how are you looking at the next 5 years in terms of your long-term strategy with this issue?
It's a very different model that we're hoping to get to. So we're hoping to get to a model where we're driven not in a fee-for-service model, but in a value-based population health management model where we're getting paid per patient per month or a global payment. And again, going to that nirvana state where now we're just taking care of you and I don't have to worry about collecting the payment. So again, are we going to get to that point in my lifetime? But that's where we're moving. And that's where we want to be, is in a different place. We think that's what the entire country needs to do. We need to fundamentally shift the way that we are getting reimbursed for the care and the incentives that we're doing. It is, how do we keep patients healthy? How do we keep them out of the hospital, out of the emergency room? And what do we need to do to be able to do that? And don't tie that to the number of clicks, how many CT scans I get or how many operations I do. It's the total cost of care. And so that's where we're going and thinking. But we've got to make it to that point, and we've got to still collect the payments that we need in the meantime to get there.
Yeah. I think that's a really great place to end. We're at the top of the hour. Thank you both so much for sharing your insights on this really important topic.
Thank you. Thanks for having us. Oh, sorry.
And to our audience, thanks so much for tuning into this webinar today. We'll be sending out an email following this event with a link to watch on demand. Please also stick around for the survey following the event. We would love your feedback. And we'd like to once again thank our sponsor, Cedar. For more information about them, please visit cedar.com. Thank you so much, everyone. Have a great day.